So, let's see. All right, so tonight we are going to talk about integumentary system. This is going to be the last of material before you have your exam, which I believe is next Tuesday. I don't have the calendar in front of me, but I think that's correct. So after we're done here tonight, I will open up the, I think that's it, right? Do you have an exam next Tuesday?
Yeah.
You should. Okay. I will open up the exam review, and then you guys will have that. So this will be the last bit of material. All right. So when we think about the body and the different areas of protection that we have to protect us from things, we think about our skin as being that body's first line of defense. So it protects all of the underlying structures that are underneath of our skin so that it can't get through to cause any infection. So you always want to remember that anytime you have any type of break or disruption in the integrity of your skin, there's obviously the potential for some type of infection, which we know, depending on that host's immune system, could be life-threatening. So as nurses, we want to be able to really know how to identify any type of risk factor that's going to predispose a patient to a break in skin integrity. So one of the most common things that we should always think of is that person that's in the hospital that's not ambulating, that's not moving, and then they might be incontinent, right? Because we worry about, you know, limited mobility, not being able to reposition themselves in bed, having issues with urinary incontinency. These are all the things that can predispose a patient to having skin breakdown, which then can lead to an infection. It's also our role to intervene to prevent or reduce a patient's risk for impaired skin integrity. So it starts with us. So really doing those good Braden score assessments. We're going to talk about that tonight. Seeing, is our patient at risk for developing some type of a skin breakdown? Are they incontinent? What can we do to keep this urine and stool from sitting on their skin? So we spend the most time with the patient. This is never going to be an order that you see. It's just an understanding. It's using your critical thinking and realizing what your patient is at risk for and being able to implement things to prevent those issues. And then if for some reason your patient does have a break in that skin integrity and they do develop some type of a wound or some type of an infection, or even if they come to you with a wound or some type of skin infection, then it's up to us to be able to provide wound care to that patient to make sure that that infection heals and to make sure that it doesn't get any worse. So resistance to injury is always going to be affected by a couple things. So if we think about our older patients, we know that as they get older, they lose a lot of subcutaneous fat, which means that instead of their skin being very, very elastic, it becomes very, very thin. And because it's thin, it can break, you know, you can have a break in their skin integrity very, very easily. So actually, I was at an estate sale on Saturday with my husband, and there was a man that was out back. They had it was like a abandoned house. There was no one living in it, and they had a concrete in the backyard, and they had just a lot of stuff piled up in the backyard. And there was a man there who was on a blood thinner, and he was 82. Well, he fell over one of the planters in the yard, and he kind of like landed, you know, with his arms out. Well, when he got back up, there was literally blood everywhere. He had these huge skin tears on his left forearm. He had like 4 or 5 on top of his other arm, and literally his skin just tore because the skin is just that fragile. And most of you by now have probably seen a skin tear. A skin tear is really just that, where you would just take an opening of the skin and pull that whole first layer back. And of course, then he had problems with bleeding because he was on a blood thinner. So it was a little bit of a situation. But being older like that, not having that good subcutaneous fat, that really puts you more at risk. And then we think about illness too. What about our patients who are diabetics, or they might be on steroids, or they might be on some type of an immuno modification medicine? These are all things that can lead to our patients having a difficult time being able to heal. So those are things that we want to think about, especially our diabetics, because anytime their blood sugar is not controlled, we're not going to get good, you know, we're not going to get that good, healthy blood that area to be able to heal that wound. Keeping patients adequately nourished and hydrated it's going to be very, very helpful, okay, to help resist injuries. So we as nurses always focus on protecting the skin and maintaining that skin integrity, because we know it's the perfect storm if we have this older patient who's not moving, but their skin might be intact. You know, time is very important. We have to be very careful about monitoring that skin to avoid any type of skin breakdown. Any type of break in skin integrity can occur from, like I said, traumatic injuries. Maybe we went in and performed some type of a surgery on the patient and actually created that wound, and then pressure as well. So just laying in that bed and not moving. So when we think about what that normal assessment looks like for our patients. So their color would be normal. For ethnicity, their temperature should be warm, their skin should be dry, and we don't like it to be flaky. Obviously, this is an issue with some patients, especially our older patients, so it's good to use cream and stuff like that to keep their skin nice and moisturized. And every client should have a skin assessment with each shift. So you will have documentation that you'll have to do as a nurse. One of the things you'll have to do as a nurse is you're going to document a head-to-toe physical assessment. There's a huge integumentary section in that normal head-to-toe assessment. And then you'll also have to do a Braden score assessment on every patient every time. But like all the other things we talk about, I want you guys to realize that these are not just once a shift. They could be if your patient's not at risk and nothing changes, but you always have to know that there's a possibility where you might have to perform another. So your patient came into the emergency room and they were walkie-talkie, who maybe they came in for pancreatitis, but then all of a sudden they got an infection while they were in the hospital, and then they had skin breakdown because they were having diarrhea, whatever the case. When they first came in, they might not have been at risk for skin issues because they could turn themselves. But now maybe they're dehydrated, maybe they're not moving as much, maybe they're, you know, constantly having stool in their skin. So there might be a time where you might have to go back, look at that assessment again during that shift and say, you know what? I put my eyes on this patient this morning and I asked her if she was able to reposition, and I came in 2 hours later and she's still in the same position. So now I have to implement measures to turn her. And sometimes that looks like you actually turning the patient, or it requires you to walk in the room and just say, hey, can you do me a favor? Let's reposition. You were in this position the last time I was in, and it's 2 hours. And sometimes they can do that on their own with just a little bit of prompting. Sometimes we have to actually initiate that ourselves. And we know that in order for everything to work in our body, for wounds to heal and for all of our organs to work, we need to have good circulation. So that is another thing we have to remember with patients. All right, so we know that one of the things our skin does is it serves as protection. So it is that initial barrier to any type of water, all the yucky microorganisms out there, and any type of damaging ultraviolet rays that we get from being out in the sun. It serves as protecting all of those important cells that are underneath the skin, keeping it from getting an infection. It protects us against injury to those other underlying tissues and organs. And it prevents the loss of moisture from the surface and underlying structures. So again, another thing to think about, especially with those older population, they don't hold in as much moisture anymore. So it's a lot easier for them to become dehydrated. It also helps with temperature regulation. So we can draw heat from our skin as we start to perspire and sweat. Sweat starts to evaporate. Our skin can dissipate heat as blood vessels in the skin start to dilate. We are able to compensate for cold conditions. So if we're really cold and our body inside is cold, we can constrict our blood vessels in the skin to diminish how much heat is being lost through our skin. So more of these compensatory mechanisms. And then we can compensate for cold through contraction of our pilomotor muscles. So that's basically our goosebumps. You know, our pilomotor muscles cause the hair on our arms and our legs to stand on end, and it has to form a layer. Once we form that layer of air on the body, it serves as insulation. So you may have heard it as goose flesh or goosebumps. People call it different things. We know that our skin is responsible for radiation and conduction, and evaporation and convection as well. It also plays a very important role in sensory perception. So being able to provide that sense of touch. Can the patient recognize pain? Can they recognize pressure and temperature throughout all of those nerve endings? So a good example of an issue with this process might be that patient who it has neuropathy, who doesn't have any sensation in their lower extremities. Sometimes it's just the feet, sometimes it's just the calves. It can go all the way up into their thighs. So if they can't, you and I, we sit on our legs, say we sit in our chair and we're sitting on our foot. After a couple minutes, 10 or 15 minutes, we're going to start to get pins and needles. We're going to feel that it goes to sleep. So that's going to tell us, hey, we need to switch positions. Patients that have neuropathy and other sensory issues don't get that. So they just continue to stay in that uncomfortable position, which then leads to, loss of nerve conduction and damages the skin and things like that. It allows the body to adjust to the environment through those different sensory impulses, works together with your brain and your spinal cord. We have these mechanoreceptors that help detect touch, location, being able to sense, do we feel certain things here or there? Is there any pressure? Do we have any pain? Things like that. And then we have thermoreceptors that are used for being able to have the sensations of heat and cold. So again, thinking about those patients that have diabetes, that have neuropathy, they might not be able to feel if their feet are cold or if they're being burned, which is why we caution them very carefully about getting baths. And if they have a wound in that area, they might not be able to identify it. So very, very common thing that we see in the emergency in the emergency room all the time, or diabetic patients come in that don't have good feeling in their feet and they come with an infection. We don't know what the infection is coming from. We set off blood cultures, but then once we do that good toe physical assessment, we find things that are in the bottom of their feet. So maybe they stepped on something and it got lost in their foot, but they don't know it. Okay, so that's why we do so much talk with our diabetes patients about making sure you monitor your water temperature, doing the cleaning of the skin, drying off in between your toes, wearing good shoes, all that kind of stuff. We know that our skin serves for vitamin D protection as well. So whenever we're in the sun, it's going to cause our body to be able to produce vitamin D. It helps with absorption. So if we're thinking about local and systemic effects, any type of topical medication that we put on the skin, things like that. And then it also plays a role in elimination. So thinking about when we're sweating, in order to keep us from being overheated and things like that, we'll start to sweat. Definitely can lose some electrolytes and things like that. And then it has a role in chemical synthesis as well when we think about being out in the sun and then being able to synthesize that vitamin D in our body so that we can actually use it. All right, so this is a good example of our skin. So our skin typically has 2 layers. You guys definitely need to know this for your exam. So you have epidermis, which is that outermost layer that you can see there in the picture. So our epidermis is going to be replaced every 35 to 45 days. Then we have our dermis, which is underneath of that epidermis, which is a little bit more rigid, and it creates kind of like a unique pattern of a finger when we think about our thumbprints and things like that. So it helps to be able to grip and hold on to objects. Inside of our dermis is going to be our subcutaneous tissue. So this is going to be our skin that's attached to our muscle, to our bone. We also our subcutaneous tissue, our fat tissue, also helps connects to our connective tissue. When we think about what gives each person their individual skin color, that has to do with the melanin in our skin, which is going to be different for everybody. And then that epidermis contains the ridges that help to compromise our fingerprints. So when we think about in detail about thermoregulation, so radiation is when our body gives off heat waves, so heat loss through the head. So how can we prevent that? We can put on a hat. We do this a lot with our babies, our little newborns, because they lose a lot of heat through their head. So we like to put them in hats all the time. Conduction is where heat moves from motion, which causes cooling. So when we think about a good example of that is a fan blowing across a warm body. When we think about evaporation, So this is anytime we're having any type of sweat loss, the loss of fluid. It could be some type of an insensible loss, or it could be a more measured type of a loss, depending what's going on. And then we have, I'm sorry, I got these reversed. Convection I did first. I talked about convection first. So conduction is next. This is the heat transfer to a cooler object. So this is when if we were warm and we put our hand on a cooler object, we could see a conduction in heat transfer. All right, so thinking about our hair and our hair follicle. So our hair originates in the hair follicle you're going to find in the dermis. That's where it starts. Sometimes some of our more woolly or wispy hair texture we call vellus. We have a lot of that in some different areas of our body. When we think like sometimes on the face, especially for women, we might have what's called peach fuzz. Not necessarily the case for men because they're more used to shaving and they grow a lot more face hair.
Hey, Mr. Davis,
yeah.
You're breaking up like really bad.
It's because somebody doesn't have their microphone muted, so it makes the audio chop.
Yeah, everybody got to mute because it's just like breaking up every other word.
Oh, okay. Can everybody please mute their? I might be able to see who's not muted. I'm not sure if I can. Let me look. I have a problem getting back to my stuff once I leave it. Okay, here we go. I can't see. It looks like from what I can see, everybody is muted. Is this better, Chelsea?
Much better.
Okay. Were we recording this whole time? Yes, we are. Okay, just making sure. All right, let me get back to my slides. All right. When we think about terminal hair is going to be coarser. Okay, we start to see that our terminal hair starts to develop in puberty. It develops in our axilla, so under our arms and our region, and face for men, our arms, our chest, and our legs. We need a certain amount of good keratin and amino acids in order to have good growing hair. Our scalp hair grows the most rapidly. So if you think of all the places where we grow hair on our body, our scalp hair is going to grow the quickest. Our hair growth does slow by midlife. Kind of everything by midlife starts to slow down. And then decreased melanin production is what contributes to us developing gray hair as we get older. All right, so thinking about our sebaceous and our sweat glands. So our these are going to be connected to each hair follicle. So each individual hair follicle that we have is going to have a sebaceous and a sweat gland. So their job is to create sebum, which is an oily substance that helps to lubricate, that keeps drying and cracking of our skin and our hair. So obviously, a lot of different people secrete sebum at different levels. So some people have very dry hair and very dry skin. So we would say that they had less, and some people tend to be a little bit more oily. So they probably have more production of those oils. These glands are definitely more active during puberty. So we see a lot of oil on the forehead, on the nose, on the chest, and the back, which is why it's so important to educate those teens to be able to really wash their face during this time because they can develop acne and other things. When we think about our sweat glands, we have what's called an eccrine gland and an apocrine gland. So our eccrine glands secrete water and electrolytes. So when we think about sweating, and then the apocrine gland secretes sebum, which is found in the nipples. It's also found in the anogenital region, in the eyelids, in the mammary glands of the breast, and then in the external area of the canals. the ear canals. So what are some of our developmental considerations that we need to think about? So thinking about those younger children on the other end of that spectrum. So thinking about those kids that are less than 2 years old, their skin is thinner and weaker than it is when they become adults through midlife. Infant skin and mucous membranes can be very, very easily injured. So anytime we have a break in skin, we're worried about an infection. Children's skin becomes increasingly resistant to injury and infection. So as they get older and more things start to develop along with their immune system, then they create this nice barrier that prevents them from developing as many infections. And then aging overall, thinking about those skin structure changes, when we think about that epidermal, when maturation of those epidural cells is going to be prolonged, we know that that's going to lead to thinner skin and then easily damaged. So definitely thinking about those older adults. And then we think about how much collagen we have in the body. Collagen formation is then going to be impaired as you get older, which leads to that loss of subcutaneous fat, that skin not being as elastic as it used to be. So then again, we're susceptible to more damage. All right, so what are some causes of skin alteration? So very, very thin and very obese people are more susceptible to skin injury. So both ends. So we think about fluid loss. It can cause dehydration. And then we think about our older people, we think about that skin becomes very loose and it becomes very flabby. Excessive perspiration during illness can definitely predispose skin to skin breakdown. So just thinking about someone who has a bad case of pneumonia and they're running temperatures all the time. Okay. Maybe when their temperature breaks, they're sitting in that gown and that gown is wet. So we have to be very on top of recognizing that fever, giving them analgesics to take care of that fever, and making sure we're being mindful about bathing the patient, changing their gown, changing their linens, and things like that. Another issue that we can see is jaundice, because jaundice with any type of liver issue can cause skin not only to yellow, but it becomes very, very itchy as well. So one thing you will notice about your patients that have cirrhosis of the liver, that have alcohol issues, they can develop cirrhosis of the liver. They will always be very, very, very itchy. So a lot of times they take Benadryl or they take a medication called Atarax, because that jaundice causes that the buildup of the bilirubin inside the body causes the skin to be very, very itchy. Another cause of skin alteration is just going to be any type of disease that develops on the skin. So some of the most common things that we see are going to be eczema or psoriasis, which cause these patchy areas to develop on the skin. So they would obviously require to be treated by a dermatologist. All right, so what are the tests that we might see when we're diagnosing anything with the integumentary system? So definitely as nurses, visual inspection. This is the best way to look at your patient from head to toe. So anytime you have a patient that has impaired mobility, or they're a little on that older side and you know that skin is thin, you definitely need to do a good visual inspection on their body, because we always need to have that baseline. Even if there's no issue there when they come in, we need to document that as such. Because what happens to the little old lady who comes in and she's, walkie-talkie when she comes in, but she's coming in for pneumonia, but she starts to, God bless you, she starts to go south when she comes in, right? Things go downhill, and then she ends up in the ICU. Well, she could very easily develop a wound if she's not turned properly and if no one picks up on it. So we want to be able to, document that she didn't have that when she came in, or we want to be able to say that she did have something when she came in. Because remember, if you don't document that they had it when they came in, then the hospital owns it, even if it happened at home. So that's why we are in a great spot in bathing and things like that to always do a great head to toe visual inspection. We can do culture and sensitivity tests. So if we have a wound or a rash or anything draining, we can just send off a swab to see what's growing, to learn how to treat it. Sometimes patients end up doing allergy tests if they have an allergy and we don't know what they're allergic to. The Woods light examination, this is not something that you need to know as nurses. You don't need to know for testing. It's something more so that they do in the dermatological setting. Potassium hydroxide test as well. You don't need to know that. That's also something that we see done in dermatology. Fungal cultures, which kind of goes in line with your culture and sensitivity. You can identify if it's an infection, if it's a fungus, and then sometimes we might have to take a skin biopsy. So if we think it's questionable, we want to know if it's cancer, or if we just really don't know what it is, and we've sent out a culture and it doesn't tell us anything, we might have to take a bigger piece of that and send that off as a skin biopsy. So when we do a biopsy, this is going to be where they go in and they take a sample tissue to be able to send off to the lab and look at it under a microscope. So they can take tissues and they can freeze them, they can place them in formaldehyde, they can stain it, they can do a lot of different things with it. It just depends on what they're trying to rule out. A lot of biopsies, especially our skin biopsies, can be done under local anesthesia. And then we do a lot of biopsies to find out if we have any type of malignancy. In dermatology, you can do other types of biopsies as well. So you can do excisional biopsy where they go in with a scalpel and they actually excise the whole thing or a portion of it and send it off. They can also do a punch, which is a tool that they can use to kind of go in almost like a hole punch that makes that kind of a circle, pull out a piece and send it off to be tested. Sometimes we have to do skin scraping. So a skin scraping would be if we have some type of a lesion on the body, they take a scalpel or a special blade and they go in and they scrape pieces. So they take basically some of the cells from that wound or whatever they have going there and they put them in a sterile container. They keep that sterile container usually at room temperature. And then they go in about 2 or 3 weeks later to determine if they think it's a fungus, what type of a fungus it is. This is probably a little bit more invasive than a biopsy. It doesn't sound like it, but it is definitely more invasive because of how much you're taking off when you scrape. The last two you don't need to know again, but a Woods light examination is when you look at your skin and your hair under an ultraviolet light. Again, very non-invasive. You can look at any type of skin infection if you're thinking about if there's any kind of dry skin or fungus, or if you're thinking about lice or things like that. And then the potassium hydroxide test is used for fungal infections that are not fluorescein. So they would take scrapings of that skin and they would put it into a container with some potassium hydroxide, and then it would be heated up, and then they would take it when it met a certain temperature, and then they would look at it under a microscope. All right. So more about our integumentary assessment. So when we think about doing an assessment on our scalp and hair, so we learned how to do this in our first semester. It was part of that head to toe physical assessment. Obviously, this is not something that we do with every single patient every time. We do this if we really think that it is warranted because we see something or we have an idea that there might be a reason for us to go ahead and look further. So if we are doing a scalp or some type of hair assessment, you just want to do little sections at a time, separating the hair in different random areas, looking for whatever it is you're looking for. If you think there's an injury to a part of the head, you would just pull the hair back into pieces, look in that area. If you're doing an overall assessment, look for something in particular, you would just do random spots. Hair assessments do not just have to be contained to just the head. So we talked about all the different areas on the body where we have hair. So any of those issues, any of those areas that grow hair could have issues. So you might have to do an assessment in those areas as well. Ideally, we always want our skin to be very smooth. It should be dry. We want it to be intact. We don't want to have any open areas. We don't want any lesions growing on our body at all. When we are doing a skin assessment, we're always looking at the color of our skin. So we're looking for what color is their skin normally? Is it normal for ethnicity? Is it blue? Is it purple? Are they cyanotic? What's going on with this patient? What's the texture of their skin? Is their skin swollen? Is it very, very dry? And then looking at the distribution on the body of the skin as well. So especially when we think about the older patients with their skin being so thin, they might present with a lot of bruisings and things like that. So any kind of abnormal findings when we're looking at scalp and the hair, we're looking for nits or lice, scabies, bed bugs, things like that. And then any kind of flaking skin. Flaking skin is very, very common in every part of the body in our aging population. So that is a common finding, not necessarily normal, but it is common as they get older because they lose a lot of oils in the body. So doing that nail assessment, when we're looking at those fingernails, when we're doing capillary refill, we definitely want to be looking at their hands and their nails as well. So we're just looking for normal structure. We're looking at the thickness or the color of the nail bed. Definitely checking out that capillary refill, which would be less than 3 seconds. We know our patients that have had long-standing oxygenation issues, we may see some clubbing of their fingernails, but we also may see in our patients who are iron deficient, they might have concave fingernails. So other things that we can look at with our nails is are they hard? Are they soft? How much keratin do they have in their body? Are they missing toenails? Do they have good refill? You know, some patients, especially if they don't have good blood flow to the area, they might have gangrenous extremities. They could have fungus on their fingers and their toes, which could have black, yellow, or hard nails. All things like that we would want to do a good visualization of and make sure that we document. All right, so you definitely need to know your Braden scale for your next exam. So we do a Braden scale assessment on every single patient that comes into the hospital at least once a shift. It is part of your mandatory documentation. Like I said before, there's a possibility where you might have to take a look at this twice if things have changed for patient, either for the better or for the worse. So we use this Braden scale assessment to be able to assess our patient's risk for developing a skin breakdown. So the different categories that we look at are sensory perception, moisture, activity level of the patient, what's their nutrition like, and then friction and shear. The computer will automatically give you a score. The lower the score, the more at risk you are. So 19 to 23 is perfect. They're not really at risk at all for having any type of a skin breakdown. 15 to 18 represents a mild risk for skin breakdown. 13 to 14 is a moderate risk. 10 to 12 is a high risk. And then 6 to 9 is a very high risk. The other thing you have to think about with this Braden score, if you receive any score 18 or lower, you automatically have to implement an intervention, and you have to document that you did that intervention. So if you did this assessment and it said your patient has 16, which meant they were at mild risk, lower on the scale, but they are a risk. So now you have to document the risk, and you have to document what you are doing to prevent that risk from developing. So maybe you're elevating their heels. Maybe you're turning them every 2 hours. Maybe you're ordering a nutrition consult. Maybe you're getting some heel boots for them. Whatever you're putting down, calmoseptine on their bottom, or you've implemented a, an external female catheter. Same thing for the men. Maybe you put on a condom catheter to keep them dry. You always have to document what you did. So if we go on and look at what this Braden scale assessment looks like. So this is all categories that it looks like. So this is, when I first started working, I remember that I tried to do it without looking at this, and a lot of times I wasn't scoring my patient correctly. But after you learn this scale, it looks like it'll get a lot easier. So sometimes if you're confused, you can look and see what your possibilities are. So let's look at the first one, sensory perception. So sensory perception is your patient's ability to respond meaningfully to pressure-related discomfort. So if you have a diabetic who has neuropathy, they might not be able to feel that their skin is breaking down on their heels if they don't have any feeling in their feet. If you have a patient who's a paraplegic, they might not be able to feel that they're getting skin breakdown on their bottom or their legs because they don't have any feeling. Certainly your patients who are sleeping all the time, or if they're in, they're vented and they're in a medically induced coma in the ICU, these patients are at higher risk. So then we have to choose, well, are they completely limited, very limited, slightly limited, or no impairment? So for no impairment would mean they respond to verbal commands. They have no sensory deficit, which would limit them to feel, voice, or voice pain or discomfort. Okay, that's pretty self-explanatory. Slightly limited means that they respond to verbal commands, but they cannot not always communicate. Okay. They can't communicate discomfort, or they need to be turned, or they might have another type of sensory impairment which limits their ability to feel pain and discomfort in 1 to 2 extremities. All right. So then if you go down to your next one, which is very limited, this is where a patient can only respond only to painful stimuli, cannot communicate discomfort except by moving or restlessness, or they have a sensory impairment which limits the ability to feel pain or discomfort in over half of the body. And then completely limited is they're completely unresponsive. They do not moan, flinch, or grasp to painful stimuli due to diminished level of consciousness, or maybe they're sedated, or they have a limited ability to feel pain over most of the body's surface. So if you're really unsure which one it is, you just go back and you read these individually, and that kind of tells you exactly where your patient can be, and then you can assign it the appropriate number. So then next on our list is moisture. So this is the degree to which skin is exposed to moisture. So we're definitely really thinking about, is our patient incontinent? Do they have a pure wick? How much are they using every time they come in? And here it tells you a lot of information that you need. So for very limited, the skin is often but not always moist. It has to be changed at least one shift. Okay. Where rarely moist requires changing only at routine intervals. So these explanations really guide you. Then we think of activity is the degree of physical activity. What are they able to do for themselves? Can they move independently? Can they move with assistance? Can they even move at all? And then what is the mobility? What is their ability to be able to change and control body position? And then what's their nutrition? Because if they don't have good, adequate nutrition, then we know they're not going to be able to heal properly. They're not going to have that good protein. So they're at risk for developing skin issues. So I never give anyone an excellent, because I may have patients that eat most of their meal, but they usually eat a total of 4 or more servings of meat and dairy products. That doesn't always occur. Okay? So I don't ever give anyone an excellent. Most people, if they are warranted, I will give them an adequate. And then you have to be very careful with your probably inadequate and you're very poor. So this is really important that you think about these when you are scaling your patients, because maybe they need a nutrition consult. If you're choosing very poor or probably inadequate, then we need to be intervening with these patients. So we need to have TPN, we need to have nutrition at the bedside, we need to definitely have a nutrition consult. And then we have friction and shear. So thinking about friction and shear, I know we talked about this last semester, thinking about, you and I, if we go to get up off of bed, we just hop right up. Some patients may pull themselves, right? They might speak against that sheet on top of their bed. That is going to create friction and shear. So that is something that we want to think about. How does the patient get up out of bed? Are they having that shearing, their skin's going one way and they're moving another way? Because especially, you have that older patient who has thinner skin and maybe they're suffering from nutrition issues and they already have skin breakdown, it's going to become even worse. So this assessment is very, very important for you guys to do adequately when you are taking care of your patient.
Ms. Davis, you're still breaking up a lot, so.
I'm connected to my internet in the office, and it's not telling me that my internet is unstable. And usually it does. Does everybody here have their microphone muted? Let me see if I can view everybody here. I guess. I'm just looking at everybody. It looks like everybody that I see is muted. Is it any better now? Is it still breaking up?
I mean, it's better now, but like once you start talking, then it starts to like break up again. So I don't know.
Does it just sound scratchy?
Like every other word is like broken.
Say that again.
Like every other word is like kind of broken. Like you'll start talking and then
Yeah, the sentence is fine.
Well, go ahead. Start. Let me see.
Is it sound broken up for everyone?
It's good now. It's good now.
But was it broken up earlier for everyone or just some
Yes.
people?
Yes.
Yeah,
Yes.
it was broken up.
Yeah.
I was only catching like every other word.
Okay. Well, I am recording this, so you'll definitely be able to go back and look at it. Usually, I mean, I'm connected hardwired to the internet because I don't have great internet where I live, but it doesn't say that my connection is unstable. So I don't think it's on my end, but I guess just let me know if it doesn't get any better.
When we rewatch it, it won't be broken up since it's like breaking up during recording.
It should not break up because it's recording right from me, right here where I am, picking up on my end. So it shouldn't be broken up. I record lectures all the time from my other class, and it's never an issue. So you'll definitely be able to rewatch it without having any issues. How is it now?
It just did it again when you were saying that.
Sounds better though. I mean, when you were talking regular, it sounded better.
Okay. Let me see. Sophia, my granddaughter's behind me. She's making a little bit of noise, but I don't know if it's her. You want to take them on Nani's bed and play with them? Yes, take them on Nani's bed in case it's making noise because the kids can't hear. Let me see if that helps. I'm just going to have her. She's playing with some stuff on the ground. I don't know if it's maybe her wrestling could be doing it, perhaps. Let's see. Forgot where I was. Okay, so Braden scale. So once at-risk clients are going to be identified, then like I said before, you really need to make sure that you as the nurse are implementing those measures, okay, to reduce them from getting any worse. And then you have to document it. So if you are a great nurse and you recognize that Mrs. Jones has skin breakdown and you turned her every 2 hours and you put calmoseptine on her and you bathed her and you changed her linens, you did all of this, but you didn't document it, then it can come back to you and it's going to look like you never did it, because if it's not documented, it's not done. So if you do all that, please make sure that you're going the extra mile to make sure that it's documented. We can make sure that we're promoting mobility by turning and repositioning those patients every 2 hours. We can also put them in a lift. We can get them out of the chair so that they don't have to be in the bed. Even if they're in the chair, we can still reposition them every 2 hours by putting something under their bottom. We should be definitely looking at those patients very frequently to make sure that we're looking at that skin, especially if they're incontinent, making sure that their skin is clean and dry. We can massage any bony prominences if the client's skin blanches with pressure relief. So when we think about somebody's skin breakdown, so if I have Mrs. Jones and I notice she's not moving, I go to change her because she's incontinent and I look at her bottom and she's got this big round red area on her bottom. The first thing I want to do is I want to take one of my fingers, push down on that red area, and I want to see if it blanches. So if you just do that to your finger and you push down, you should see that it turns white and then all that blood flow comes back to that area. That's great. That's what we want to see because we know we're getting good blood flow to that area. If you push on that wound and it does not blanch and it just stays white and no blood comes back, that's a problem, because we know now that this skin doesn't have good blood flow, and there's a very high probability now that she's going to have skin breakdown. So we definitely don't want that. So we need to make sure that we're really looking at those areas, massaging the skin, putting lotion on. We can use absorbent pads or briefs that will wick and hold moisture. So this is another thing for you guys to think of in the hospital. So where I work, we generally have a rule. I don't see a lot of people adhering to it, but we have the rule that we should only put one chuck under a patient at a time, because chucks are great. They whisk that oh my God, sorry. They wick that fluid away from the skin, right, to help keep their skin dry. But if you have more than one of them under a patient that has skin breakdown, then you worry about that good airflow coming up underneath of them, which can also lead to more skin breakdown. So a couple of different things you have to think there. So ideally, we only want to have one chuck under a patient at a time. thinking of a topical skin barrier or a fecal containment pouch. So sometimes if you have a patient that has C. diff and they're having loads and loads of liquid diarrhea, advocate for that patient to have a fecal management system, okay, put into the patient that gets inserted into the rectum, and it's kind of like a Foley, and all of that stool just comes out and it goes down into a bag, which you can drain. Definitely helps with keeping that skin from getting broken down. And if they already have a wound there, it will help with wound healing as well. We always want to use a moisturizing skin cleanser rather than just like a soap that we would buy over the counter. So it's, even though family members want to bring things in, it's better that you always just use what we have in the hospital, because that's better suited for these areas. Is it any better, or is it still breaking up?
Much better.
Yeah,
Okay.
better.
I wonder if I was talking too loud. I'm going to try and talk quieter. Definitely thinking about those pressure relieving devices that we can put on. So, you know, you can put, sometimes if the skin is really, really bony around the elbows or on the bottoms of the feet, we can put those border foams on them. We can prop the heels up so that the heels aren't touching anything. Repositioning them in bed, all that kind of stuff. So they have these things called donut devices that you can just like sit the patient in, where the inside of the middle was cut out like a donut. Those are things that we don't really like to use because it can cause skin breakdown in other areas. So we typically don't have those in the hospital. Padding certain areas of the body that are subject to more pressure is always something that we want to do. Definitely want to try and avoid that friction when we are moving patients or helping them up. So when we think about friction, again, it's just that effect of that skin rubbing against something else, okay? When your skin's going one way and you're being pulled in an opposite direction, you're going against the bed or the chair, whatever the other object is, it can cause shearing, it can cause the skin to rip. So we have to be very careful. Using a lift sheet is always helpful, and then always using a lift in the hospital if you have that. We should also be looking at their nutritional content. So sometimes you can just call and ask the doctor and say, hey, you know, the patient isn't really eating very well. Can we do a nutritional consult? Can we have nutrition services come and talk to them? Can you just add an Ensure to their diet? There's a lot of different things we can do. And then we want to make sure that we are helping to support the patient being hydrated throughout the day to make sure that they're not getting dehydrated. So offering them lots of fluids. All right, so now, hold on.
I'm kind of.
Go out there and do it. Please go out there and do it. You can turn on Nani's site. I'm sorry.
It's not making any noise.
So the types of wounds that we have. So this is important. You definitely are going to need to know all about these wounds for your exam. So we know a wound by definition is any type of physical injury that causes any kind of skin breakdown to our skin or our mucous membrane. Sometimes we might have an intentional type of a wound. So your patient comes in to have their gallbladder removed. We do a lap chole. That's intentional. We make that surgical incision on purpose. But when we do that, typically we're in very clean, sterile environment, right? Like the emergency room or something like that. So that definitely helps to minimize the risk of infection. Any unintentional type of a wound would be, you know, did your patient accidentally cut themselves with a knife? Did they fall down and they have an abrasion on their skin? Did they have a puncture wound? Maybe they got bit by a dog. Anything that would occur in any type of unsterile environment. So we know any of these unintentional wounds are going to be at the highest risk for infection, okay? And because they're at a higher risk for infection, we know that it's going to take a lot longer for these wounds to heal. So an acute wound would be, you know, a wound that heals fast from surgery, and they're at a very, very low risk for infection. Chronic wounds, which we see all the time with patients that have diabetes or they have coronary artery disease. So thinking about patients that have any type of arterial or venous insufficiency, not getting good blood flow to and from an area, or your patients that have pressure ulcers, so decreased mobility, skin breakdown, or edges of a wound that are not approximated will take longer to heal as well. When we think about partial thickness, full thickness, we're thinking about the dermis. So partial thickness and full thickness are both going to be injuries to the dermis, excuse me, and the subcutaneous tissue as well. So getting that picture in your mind of that slide we saw a couple slides back about, you know, the different layers of the skin. And that's going to be good for you guys to really remember for your exam. When we think about a wound that could be open or closed, so sometimes we might have a contusion that's caused by some type of a blunt instrument. It may result in bruising or a hematoma. Okay, so the skin never opened up, but now we have this blood collection underneath the skin. An abrasion is going to be rubbing or scraping of those epidural layers of the skin. A laceration is going to be the tearing of tissue with a blunt or irregular instrument. And then an avulsion is the tearing of a structure from its anatomical position. So if you were to have a break or something like that, where the bones come out of where they're supposed to be normally aligned. All right. This is also important for you guys to know for your exam. So when we think about how wounds heal, we think about they can repair themselves one of three ways. So we have primary intention, secondary intention, or tertiary intention. So you definitely need to know all of these. You have to have a good understanding of all of these. So if I give you a example of a particular wound, you want to be able to tell what this wound would look like, okay? Depending on what, how it was healing. So if we think about primary intention, this is where the wound is well approximated. So that means that the edges of the skin are held pretty tightly together, okay? So intentional, any type of an intentional wound repair is going to be with, you can imagine a wound that has very minimal tissue loss, okay? So anytime we go into a surgical incision, because they're very mindful about the incision that they make and how much tissue is lost, because, and also these wounds are approximated because they have sutures, so they're automatically brought together. So any type of wound like that is always going to heal by primary intention. Our secondary intention is going to be a wound where those edges are not well approximated. So those edges are not very tight together. So examples of these are going to be very large open wounds. So if you think of someone who had a major burn on top of the body, an area that would need to be covered with some type of tissue replacement, okay? Those wounds definitely at a higher risk for infection. They can become contaminated very, very easily. They take a lot longer to heal, and they usually heal by what we call this secondary intention. So another thing that can happen is you might have a wound that is healing by primary intention, but then it gets infected. Okay, once that wound gets infected, it can no longer heal by primary intention. It has to heal by secondary intention because it becomes more involved. It becomes larger, it becomes infected, so it can't heal by primary intention anymore. And sometimes you might have to go into that wound. Say you had a patient that had a lap chole and one of their incision sites got infected. They might have to go in there and open that up again and do a washout. And then, you know, suture everything up. So that would be a secondary intention. Any type of wound that heals typically by secondary intention takes definitely longer to heal, but you're going to have more scar tissue. Okay, so we see patients that have a lot of GI issues, that have had to have a lot of abdominal surgeries. They tend to have a lot of difficulty with healing. They almost all the time heal by secondary intention because of the bacteria in our gut and in our intestines. And then they have a lot of scar tissue in there, which causes a lot of problems throughout the rest of their life, which also causes more surgery. So that's something very common that you'll see in patients that have had abdominal surgery. Tertiary intention is going to be when we intentionally, as providers, delay closing that wound. Okay, so what we do sometimes is we have wounds that we go in and we clean out. They leave them open for a couple days because we're worried about swelling. So, you know, if you have a wound on your arm and you think there's going to be a lot of swelling in there or at the high risk of infection, we might just leave that wound open for a couple days. We want to get that edema to come down. We want to get some of that fluid to drain off. Then we go in at a later time, whatever that time looks like. There's no set time. And then the provider will go in and close that wound. But you guys definitely need to know that for your exam. So what are some things that we need to think about that are some of our guiding principles for how patients' wounds actually heal? So we know, again, the skin is the first line of defense against being able to have any type of an infection. Any type of break in that skin integrity puts us at risk for infection. So we as providers know that hand hygiene is the best way to prevent infection. So definitely when we're caring for a wound, even though that wound is dirty, we want to make sure that we are always doing good hand hygiene. When we think about how our body responds, so this is kind of a review from last semester, but if we do get an injury somehow, our body is going to respond systemically to any trauma, right? So if we have an infection, we might have increased body temperature. We might have increased heart rate. We might have an increased respiratory rate. Depending on what type of an infection we have or what's going on, we might have decreased appetite. We might be nauseated. We might be vomiting. We might have a lot of tense muscles, and then maybe even some hormonal changes too, depending on what's going on. We know that any type of a wound that we have to have a good adequate amount of blood supply in order for the wound to heal properly. So one population of patients that we worry about is our diabetic patients, because their blood glucose is usually not always controlled. We have higher rates of glucose in the blood, which makes it more viscous, and we can't get good blood flow to that area. So anytime you have, I see all the times where people will go and maybe they had to have a BKA or they had to have their foot amputated. And then when the doctor comes to change that dressing after that first after the surgery, they look at how much blood flow they have. So ideally, they love it when they change the wound and there's a lot of blood there, because that's great, because we can anticipate that that wound is probably going to heal a lot faster because there's good blood flow. But sometimes, even after we amputate the foot, we change it and there's hardly any blood flow to that area. So we don't have a lot of blood. That's not a great sign. We can anticipate probably that there might be infection and it's going to take a long time for this wound to heal because we don't have good blood supply. And what we see sometimes with some of our patients is that we have to send them to hyperbaric treatment to get their wounds to heal. So we know we need a lot of oxygen in order, if we have to have good oxygen in the body for wounds to heal. So we'll send them to hyperbaric treatment. Hyperbaric treatment is like, it kind of looks like a big coffin, but it's glass, and it's where the patients go in and they call it a dive, a DIVE, and they start lowering them down and giving them these high amounts of oxygen. But that oxygen goes right to those areas and oversaturates the body, but it helps the wounds heal. So that's something that you might see if it happens in your hospital. Let's see. Increased numbers of leukocytes, erythrocytes, and platelets go to the site of injury. So we have to have good blood supply, okay? Because we need all these things to happen during that state of inflammation whenever we get a wound. Increased circulation to the injured part of the body. We know it does a lot of different things. It helps to remove toxins. We see those phagocytes kick in and start taking that debris away. And then that good blood flow is going to provide the nutrients and the oxygens the oxygen level that we need to heal. Normal healing is promoted when the wound is going to be free of any foreign material. So what you'll see definitely in outpatient wound care, if anybody here loves wounds and they want to work in an outpatient center, thinking about that excessive amount of drainage or exudate, purulent drainage, any type of damaged tissues, any type of cells, any type of organisms that can be growing. What you'll see a lot is that people that follow up with outpatient wound cares and they go with them each week, that when they come in and they take off the dressing for that wound, they kind of almost debride it every single week when they come. So if you think of when you have you know, just pretend like you fall outside and you scrape up your whole arm, okay? And you break the skin and you have all this blood there. Well, getting all that blood there is helping it to heal. And then it's starting that inflammation process. And anytime we have that inflammation process start in the body, it's going to create this area or this environment for healing. So when somebody comes in with wounds on a weekly basis, that's basically what we're doing. So if we take a scalpel and we scrape that wound bed and make it bleed, it's kind of like starting that injury process all over again. So we get all of those white blood cells to go to the area, and we kind of trick the body into being able to heal this wound. So you'll see that done a lot in the outpatient center. They'll remove all that slough from the outside of the body. Around the edges, inside of the wound. They'll scrape the outside of that wound and pull, because sometimes what happens with wounds is that if you think about the outer layer, right around that outer layer, it kind of gets thick as it starts to heal, but it can also prevent wound healing. So they'll go and they'll remove that thick callus that's around the, the border of the wound, and scrape it really good and remove all that stuff and get it nice and bloody and red again to try and help that wound to heal. You don't see a lot of that done in the hospital setting because they usually follow up with wound care after. Certainly, if you have a wound where there's any type of metal or glass or anything like that, you would want to make sure that you were, removing that as well, because we know that the wound won't heal with all that stuff in there. The body's response to a wound is more effective if proper nutrition has been maintained. So we know this. We talked about this a couple weeks ago when we talked about nutrition. Undernourished patients, we know, are at the greatest risk for a wound infection because they don't have a good immune system. Okay, so they need a lot of different vitamins and minerals to promote wound healing. So we have to teach our patients how to increase protein in their diet. We have to talk to them about what type of vitamins they need. So ideally, when we think about wound healing, the top vitamins that we like them to take are A, C, B, K, zinc, copper, and iron. So knowing, what type of foods are included in that have these vitamins in it was also going to be very helpful. And remember, if your patient can't order their meals for themselves, then you know what type of meals to order for them. So you can order these meals that have a lot of these vitamins and higher protein for them. The ability to handle any type of alteration in a patient's skin integrity is also going to depend on their general state of health. Okay, so if you're thinking about definitely your older population where they might just be weak, they might have other chronic illnesses that they're dealing with, they also have a depressed immune system, this can be hard for them to be able to care for wounds and stuff like that when they go home. So that's another thing that you would want to think about and advocate for your patient if you know that there's a lot that they have to take care of when they go home. All right. So this is important. You guys need to know this. Definitely need to know this phase inside and out. So we have a couple different phases of when our wounds actually heal. So if we think about our hemostasis phase, this is going to be as soon as we have this injury. Immediately, right? I just cut my finger. Now I'm in this hemostasis phase. So our body is like, holy schmoly, what happened? There's been an injury somewhere. So our vessels are going to constrict. Our blood is going to start to clot because the body's like, hey, I don't want to lose all my blood. So all of our platelets are going to go to that area. They're going to cluster in that area to form a seal so no blood escapes. They're going to cluster together, and then they're going to start that inflammatory process. So next is that inflammatory phase. This phase typically lasts about 2 to 3 days in a healthy person. So during the inflammatory phase, our body's making all of these white blood cells. Predominantly, the body makes leukocytes and macrophages, and they're going to move into that wound to help take care of what's going on with that wound. After those 2 or 3 days, then we go into the proliferation phase. So this can last several weeks, maybe even longer for someone who is nutritionally compromised or has some other issues going on. So during this phase, this is where that new healthy tissue starts to fill in around that wound space, and that wound starts to heal. Usually what happens is it's through these actions of fibroblasts in the body that help gather together to form that new tissue. Then after that phase, we have the maceration phase. So this is the very last stage of healing. Again, for most healthy people, it starts around 3 weeks after that injury starts. And then again, if you have somebody who has, poor nutrition or high glucose, things like that, this can always be extended further, but typically 3 weeks. So collagen that we need to help heal that wound is going to be remodeled inside the body and remodeled inside that wound. And it's going to make that wound stronger and try to be as similar as it can to that tissue that is adjacent. And again, with younger people, this maturation phase is going to happen a lot easier. If you think about an older adult who doesn't have a lot of collagen anymore, who doesn't have a lot of subcutaneous fat, then that wound may not be as strong as, someone else's. So just something else to think about. So this is a picture of what that wound phase looks like. So you have that initial injury and you have that hemostasis and coagulation, right? That body's going to work to get all those blood cells there, all those platelets to form a clot. Then the body's going to start that inflammation process, right? You're going to send in all those macrophages to try and gobble up all the stuff that's in there. You might get a scab on top of that wound during that inflammation process. And then you're going to have the proliferative and migration stage, where everything starts to heal. And then you can see just the changes in that wound over this process. So by the time you get to the third phase, you can see how much smaller that wound is, right? It doesn't go all the way down, just the layers. Like this layer here, it's going all the way to the vessels. And then here, it's not even into the subcutaneous fat anymore. And then you have your remodeling, which is where you have this freshly healed epidermis. You might have a scar there, but hopefully that skin has remodeled. All right, so going into great detail about all these phases. So hemostasis occurs immediately after the initial injury. It involves our blood vessels constricting, sending blood to that area, all of our platelets getting together and clustering to form a clot in the body so that they stop bleeding. Only after a brief period of constriction, the blood vessels will then dilate again. Capillary permeability starts to increase again, and it's going to allow all of our blood and all of our plasma components to be able to leak out into that area that's injured, okay? Whatever that liquid is that forms around that area is what we call exudate, which is what we were talking about. As this fluid starts to accumulate on that wound, that's what's going to start the swelling because of that fluid there, and that's what's going to cause the pain. Increased perfusion to that area because the body knows there's an injury there, so it's sending lots of blood flow there. That's going to also cause your heat and your redness. Typically, if the wound that you have is small enough, the clot loses the fluid and you're going to have a hard scab that's formed pretty soon after to help protect that injury. Again, the larger the wound that you have, the more impossible this becomes, and you might not ever see that. It has to heal by a different way. The platelets are also going to be responsible for releasing different substances that tell the other cells in the body to move over to that injury to help work together to help the different phases of healing. All right, then we have our inflammatory phase. So our inflammatory phase is after our hemostasis, and it only lasts about 2 to 3 days. Blood clotting has already been initiated. Those white blood cells, remember we said just our leukocytes and our macrophages predominantly work, and they go in towards that wound. The leukocytes typically arrive first, and their job is to get to that bacteria and to take up all that debris that's in that area from the injury. Usually about 24 hours after the injury, excuse me, the macrophages, which are very much like those other phagocytic cells, but they're the really large one. They're then going to go after the leukocytes. They're going to go to that wound and they're going to sit there for longer and kind of do the same thing, gobble up all that bacteria and the debris. The macrophages are going to be really essential for that healing process because they do a lot of the heavy duty work. They ingest the debris, but they also release certain growth factors into those epithelial cells to start the healing process. We are going to see acute inflammation during this process. So you should always remember the inflammatory phase has inflammation. And anytime we have inflammation, we can have pain, okay? Definite redness to the site, heat to the site, and swelling. At this point, if we have any drainage from this wound, it's odorless because we haven't had time for any infection to settle in or anything like that. So inflammatory phase does not have any drainage that has a smell. It's odorless. The patient also has a generalized body response. So if we think about that inflammation phase starting to happen, our patients might get an elevated temperature, and we might see an increased number of white blood cells in their in the CBC that we do, because our body's saying, hey, we have an injury, and we're sending all of these leukocytes to this wound. So sometimes we will do if we don't know, you can do a CBC, or you can do a CBC with differential, which means that we can do a further breakdown of our white blood cell count and look at the neutrophils, the eosinophils, the leukocytes, all that. And if we see a high number of our neutrophils or our leukocytes, that means that we have immature white blood cells, which means they're mounting a response in the body, which is what you would see if a patient has just had an injury. Then we have the proliferation phase. So during this phase, we're going to see this fibroblastic regenerative or connective tissue phase. So we think about fibroblasts, they will help take that connective tissue and make new granulation tissue. That granulation tissue is eventually going to turn into scar tissue. But usually we have this process that happens in the background. And at first it's just called granulation tissue. So this, depending on the health of the patient, is going to last for several weeks. The new tissue is going to be built to help fill up that entire wound space through these fibroblasts, okay? So these connective tissues synthesize and secrete collagen. Again, not something that we would see happen very quickly in older adults because they don't have a lot of collagen, and they help produce all of these growth factors that will help, you know, with our blood vessel formation, and then increasing the movement of those endothelial cells. The capillaries in the body will then grow across that wound. Once we get more capillaries across that wound, we're going to get more oxygen and nutrients, which is going to speed up that healing process. Those fibroblasts that we talked about form fibrin, and that fibrin layer is going to stretch through the clot against, you know, and cover that entire wound. Then what we see is a very thin layer of epithelial cells will start to form across that open wound. And then we're going to see the blood flow is going to be reinstituted to even further heal this wound. So any new tissue that we see in our patients is going to be called granulation tissue. So this is something that we look at in wound care in the outside world when we're trying to determine how our wound is healing. If we see a lot of granulation tissue, that is great. That means that this wound is starting to heal, and then eventually that's going, all that granulated tissue is going to form what's eventually going to be that scar tissue to help end of this phase. Granulation tissue is very, very vascular. So there's a lot of blood flow through there. It's very red and it bleeds very easily. So in wounds, any type of wound that you have that's going to heal by first intention, all of those epithelial cells that go around that wound will start to seal within the first 24 to 48 hours. So granulation tissue is not something that you see very early on. And in patients that have chronic wounds or larger wounds, you don't see it for quite some time, but it is your goal that you will get nice beefy red granulated tissue. And that red tissue we would still in the outpatient wound care setting scrape with a scalpel and get it to bleed even more to push that process of healing along. Your body's going to continue to make collagen, and that collagen will continue to accumulate. And usually by 5 to 7 days, that process is going to stop. So at this point, depending on the size of the wound, that collagen will deposit and, over the next several weeks or even years, start to spread out over that wound. The older you are and the bigger the wound, the longer that it takes. By the end of the second week following the injury, most white blood cells have left that wound area now, and then that wound becomes lighter in color. Usually we don't have any systemic infections at this point. And then still we need adequate nutrition and oxygenation, because we are preventing any type of strain on a suture line. So anybody that has sutures and things like that, we don't want anything underneath of that, you know, to swell, that could cause any type of issue and allow those sutures to come open or to separate that wound. Wounds that heal by secondary attention eventually follow the same process, but again, it's by secondary intention, so it takes a lot longer, and wounds that heal by secondary intention will form scar tissue, but it takes a lot longer. How's the internet? Can you guys hear me okay still? Are you guys still there?
Yeah.
Yeah, it's better.
Okay.
Yes.
All right. So thank you. So the final phase is going to be your maturation phase. So this again is going to be the final stage of healing. Okay. It's about 3 weeks after your injury. And depending on the body, the infection, the injury, how big it was, nutrition status, this could continue for months or even years. Okay. So any type of collagen that was placed in the body in that wound during the previous period is then going to be remodeled, and it's going to make that wound stronger, and it's going to be as close to as it can be to that tissue that surrounds it. Okay, so it's going to try and even out and spread out to become one. New collagen is still going to continue to be deposited, but that new collagen is going to compress those blood vessels in that wound so that the scar doesn't have any type of issues, so that it doesn't, you know, it won't sweat. You won't see any growth in that area. It's not going to usually change color in sunlight. Eventually, it's just going to become a flat, thin line. Scar tissue is going to be less elastic than uninjured tissue, and scar tissue can just grow on top of each other, and it can cause, especially in your GI area, adhesions. And eventually those adhesions can cause a lot of damage depending on where they are. So it's not uncommon that some patients, especially with abdominal issues, have to go in and have adhesion removal because of all the scar tissue. Usually the strength of the scar remains less than that of the normal tissue. So many years after the injury, it's not uncommon that it's never fully restored. Again, any wound that heals by secondary intention is going to take a lot longer to heal and to have a scar that's formed. And then usually if you think of any type of injury that's over a joint inside the body, regardless of you know, what the wound is, scar tissue that forms over those bendable areas can cause definitely issues with movement and could cause a disability moving forward, depending on where it is and how severe it is. All right, so some local factors that we could see that would affect wound healing. So sometimes we can have desiccation. So that is basically just dehydration. So not having a lot of water. So if you look at this picture down here at the bottom, this is a picture of somebody's vertebrae. So where this line is that says desiccated disc, this is a disc that's filled with fluid that is supposed to you know, keep these bones here from touching and causing any issues. So it should look down here like this one, nice and big and plump, and it should fill in these spots. Sometimes you get dehydrated and or just because you have back issues, you become dehydrated in these discs. And what happens is we worry about these bones rubbing together. We can also worry about maceration, so overhydration. So sometimes if you have too much fluid or you have back issues, these discs can bulge. So like a bulging disc, they can actually come out of the space and then put pressure on the nerves and cause a lot of pain. Any type of trauma, repeated trauma to the same area can result in delayed healing. So one thing that you guys might see, especially with older adults who are not very mobile, you may see patients that come in that have had a stage 2 or a stage 3 wound that healed. You may see that on their body. It's pretty noticeable. Once you see it once, you'll be able to recognize it again. You'll see that hey, they must have had a wound here before. So you should always know that because they had a wound there before, that area on their bottom, more so than any other area, is more at risk to breaking down first because they've already had a wound in that area. Definitely any type of edema in the area is going to cause a wound to not be able to heal properly. So, which is why sometimes we let wounds stay open and let some of that edema to slow down, go down first before we close things up. So any type of swelling is going to interfere with how much blood flow we get to that wound. Okay. And then if we can't get blood flow to that area, we're not getting enough oxygen, we're not getting enough nutrients, and the wound can't heal. Definitely infection is one thing that we're always trying to avoid. So any type of bacteria in that wound is going to put more stress on the body. It's going to cause more inflammation. The body's going to have to work harder to be able to deal with it. And then we know it's going to prolong wound healing, and it can also cause some of the good cells that we have in that area to die. We always worry about excessive bleeding, which can be large clots that can make oxygenation an issue. Necrosis is death of a tissue. So the healing of the wound does not take place at all. We don't have any blood flow to that area. All of the tissue dies and the wound will not be able to heal properly. And then sometimes we see patients who have what's called a biofilm on their wound. So when we have wounds, when we have wounds that have bacteria, sometimes those wounds and that bacteria grows in clumps and it becomes embedded in those wounds. The body makes these little clumpy areas, and it's kind of like, if you've ever seen a really infected wound, you'll see kind of like this slimy barrier that's on there that you can actually pull off with like a 2x4 or something like that. That's a biofilm. The biofilm is basically just made up of a lot of glucose and proteins. But with any type of covering like that on the wound, it's going to decrease how well our antibiotics work, and it's going to obviously keep that wound from healing. So we're not really going to be able to get a lot of that granulated tissue like we like to see. So what we do in outpatient center and wound care is we go in and we remove that biofilm and we take it off so that way we can get that wound to heal. You don't see a whole lot of that in the hospital setting, but you definitely see a lot of it in outpatient wound care because they follow up every week. All right, so wound complications. So these are some of the things that we definitely never want to see. So an infection, right, is one thing that we don't want to see. So any type of an infection in a wound can be an increase in drainage, definitely any type of drainage that is purulent, any new redness or increased redness to that site, any pain, new or increased to that site, swelling around the wound, if the patient develops a temperature, and of course we're looking at those white blood cell count, because that's going to tell us, if our body is making more white blood cells, then that means that it's trying to fight off an infection. What you guys should know is that when we think about purulent drainage, all that's made up of purulent drainage is bacteria, debris, and white blood cells. Okay, that's all that's in that purulent drainage. And you definitely need to know that for your exam. We know that any type of increased drainage, redness, swelling, that's all going to delay our wound healing. Then we worry about hemorrhage. So hemorrhage is usually from some type. Usually we see it from a surgical wound. So this is why whenever a patient has surgery, we are very, very vigilant about checking that wound dressing several times an hour, leading up to maybe every 2 hours, then every 4 hours, but definitely within that first 42 hours. And then every hour after that, we are looking to make sure that that dressing is dry and intact and that we don't have any new drainage.
I think you're on a different slide than we see.
Oh God, I forgot to switch it. I'm sorry. Yep, I have two things I'm switching here. I'm sorry about that. All right, we're on. That's where I'm.
Okay, and the infection was what was Denise to know?
You need to know everything on this slide, but you definitely need to understand what is purulent drainage. So if we talk about purulent drainage, what is it? Purulent drainage is just those white blood cells, the debris, and the bacteria. So again, definitely if your patient had surgery, make sure you're monitoring that site very vigilantly. If you go in and the patient has a dressing and there's no blood on it, and then you come back in a little while later and there's new blood on there, you want to be mindful that you should get some type of a marker, and you want to be able to circle that blood on that dressing, because that's going to serve as a guide as we continue to monitor this wound. You know, is this wound bleeding even more? If you go back in another hour and there is now new fresh blood that is around that area where you circled, then you know that this is an ongoing bleed. Okay. I like to do it when patients come back just from surgery. Even if they have a little bit of dried up blood from the PACU, I just go ahead and circle that area just so that anybody else that comes behind me knows that, you know, this wound is stable and that it's not actively bleeding. Any type of, especially thinking about a wound and any type of internal bleeding, if you think of blood that's just building up in the body, it's going to place pressure on those blood vessels, and it can cause ischemia because we can't get good blood flow to the area, and that wound or that limb can suffer from tissue ischemia. We also worry about dehiscence. So this is something usually we see in post-op wounds. So we can experience a partial or a total separation of the wound layers, or an evisceration. So this is where an abdominal wound completely separates, and then those visceral organs will then come out through that incisional area. Okay, so we definitely worry about this. So any type of post-op wound that has an evisceration is going to be a complication of that dehiscence. So if you have an evisceration and you go into your patient's wound and into that room and that wound is wide open and you start to see those visceral organs, you definitely need to know that that's a medical emergency. Typically what we do is we don't want there to be any type of, we don't want the wound to dry out. We don't want our organs to dry out. So normally we just get a couple 4x4, saturate them in sterile water, and put it over top of that area and cover that area completely. Keep it nice and moist until the doctor can come and take a look at that patient. There are a certain population of patients that are more at risk for this than others. So patients that smoke, definitely at a high risk. Patients that have nutritional issues, so if they suffer from malnutrition. Obese patients definitely are at a higher likelihood of experience this. And then we worry about patients as well who take long-standing anticoagulants. It can also happen with people who cough or strain and they don't guard the wound. Okay, so if they don't have a pillow to kind of put in their cough when they're a lot of the times you'll see patients that have like cardiac surgery that have suture lines in their chest. If they have to cough or something like that, they'll give them like a little bear or a pillow to kind of push against them, that they hold up against them to kind of protect that suture line when they cough. The other thing that we worry about is a fistula. So a fistula is an abnormal passage from one internal organ or even a vessel to the outside of the body, or it can also happen from one internal organ to or vessel to another. So a vessel to vessel, one organ to another, or one organ or vessel to the outside of the body. A variety of different ways you can see this. Let's see. Fistulas can develop. One of the main reasons we see them develop is infection. And then what we see is that sometimes if you have a lot of fluid inside that's building up and you can't get rid of that fluid quickly, it'll collect in that area, and whatever that area is, it causes that area to become weak, and then it causes that unnatural passage to then develop. All right, so you also need to know this slide. So when we are looking at wound drainage, so the first thing you want to think about when you have drainage, especially if it's on like a surgical dressing, or if it's on a dressing that you can't, that there's just a little bit of drainage on it and you're going to come back later and look at it, you always want to make sure you're circling it like we said, okay? Dating it and timing it is also not a bad idea if you can. If you could actually see fluid and blood coming out of it, that would not be something that you would circle and leave. If you actually seeing it oozing, because then that would tell you that this is definitely an emergent issue. But if you just see a little bit of drainage, circle it, date it, time it, because we want to be able to then determine if we're having a more severe issue. Let's see. some of the drainage that we may see. So there's a variety of different types of drainage. So we might see serous drainage. So serous is always going to be clear and watery. Okay. A lot of times what you will see the most of the time with your wounds is going to be serosanguinous. So serosanguinous is a mixture of serous, which is clear and watery, and then your sanguinous, which is bright red. So sanguinous, which is bright red, is not something ideally that you always want to see. You can, if we use the example that I used of the man who had a BKA or he had his foot amputated, we go to change that wound. There's a lot of fresh red blood there. That can be a good sign. We don't want to see a lot of it. And it shouldn't continue over days and days at a time. And then purulent is another type of drainage that we can see. Usually purulent, again, has all those white blood cells in it. It can be very thick, and it definitely does not smell good. With purulent, you can see a lot of different colors depending on what it is. So it could be yellow, it could be tan, it could be green, brown. It could be a lot of different colors just depending on where it's coming from and what it is. So this slide right here shows you a good example of what your drainages look like. So on the left is your serosanguinous. So that's your, your in between. So not clear, but not bright red. So that's serosanguinous. Next is serous. So you would see, go back to serosanguinous. So serosanguinous is very common what you will see in your new wounds. Okay. Serous is going to be something that you might see from a surgical incision. So a very clean wound. Purulent always is going to be your infected wounds. Okay. If it has purulent drainage, then it is definitely going to be infected. And that last one is your sanguinous, and this is going to be from your deeper wounds or your or wounds that are in very highly vascular areas. Ugh. So for all of you that love wounds, you probably love this. So looking at the one on the right, so this is a gentleman who has a trach. And he has had a lot of skin breakdown on that skin. You can see all that well, I wouldn't say that that's necessarily purulent drainage. That's just probably mucus coming out around that site. But this ideally should be healed. So under, let's see this little teeny tiny red area here to the right? We would call that just the start of a little bit of granulated tissue, which is going to start to heal. All this over here, very pale, covered in like exudate and stuff like that, biofilm. This wound bed is not going to heal with that. So we need to keep this wound bed clean. Over here, this is an incision that has some sutures in it that has busted open, probably by infection. Because if you look up here into this middle area here, you have a lot of purulent drainage mixed with that blood, which means that underneath of that wound there is some type of infection. So remember we said if we get edema or infection in there, it can bust those wounds open again. So that's exactly what happened here. Down here on the right, this is a very significant wound, probably from a diabetic person. It has a lot of slough on it first, which is like this yellow. So in this wound, you can see a tendon right here through the middle. So we can easily stage what type of a wound this is because we see a tendon. However, if you didn't have that tendon there and you were just looking to the left or looking to the right because of all this slough, you wouldn't be able to tell what stage that wound is in because it's covered. We would have to send this patient in the hospital to surgery and do an IED to go ahead and remove all of that to try and determine what stage it is. Or in the wound care center, we just scrape that and remove that in the office. And then this guy over here, he definitely has had some, it looks like abrasions. But the purpose of circling this wound here is, especially if you have a wound that has redness, before we start an antibiotic, we want to know, is this antibiotic working? So we will look at where the redness is on the extremity, wherever the wound is, and we circle it with this pen. So that way, when we start the antibiotic, if the redness starts to come back in towards the center of that circled area, that tells us that, okay, it's controlling it, and it's starting to heal. If it goes outside of that area, which it is, in this case, you can see how the redness goes clear around that margin that they wrote on there. That means that whatever we're doing is probably not working, and that we need to change antibiotics, or we have to change up how we're caring for that wound. And this actually also has some exudate on it, some purulent drainage. This red area is what we call granulated tissue. We like that. See how beefy red it is? That is going to be good tissue. When we scrape that and make it red and make it bleed, it's going to cause that inflammation process to start all over again, which is what we want. All right, so now we're going to talk about the different types of skin breakdown. So we can have a pressure ulcer. You will also hear pressure ulcers referred to as decubitus ulcers, but really we call them pressure ulcers. Some of your older nurses may say decubitus. So this we know is preventable. This never ever has to happen, and we are the primary person who is with that patient the most that can prevent these ulcers. Okay, you and the tech. Pressure injury has replaced the word pressure ulcer, so you'll hear that used in the hospital setting. A pressure ulcer, a pressure injury is going to be any type of localized damage to that skin, okay? Usually these injuries like to occur over bony prominences where we have that loss of subcutaneous fat. We can also see that patients develop a venous stasis ulcer. So this develops in patients that have a venous insufficiency. So they're not getting good blood flow to that area, so they develop venous ulcers. We have diabetic ulcers that also develop in our patients that have diabetic neuropathy. It can just develop because of any type of little skin breakdown. Even just a little hangnail can cause a diabetic ulcer to develop in these patients. And then we have what's called incontinence-associated dermatitis. So again, this is something that is preventable. Nurses and techs are going to be responsible for preventing this. So this is, recognizing those patients who are incontinent and using good cleaner on them, putting a moisture barrier to protect that skin from breaking down, and making sure that we're keeping them dry all throughout your shift. All right, so when we think about these pressure ulcers, so external pressure is always going to be one of our biggest contributory factors. So these are going to occur over those bony prominences where our body weight is going to be distributed over a very small area, okay? And in that area, there's not a lot of subcutaneous tissue to be able to cushion any type of damage that happens to that skin. Most of the common areas that we see pressure injuries occur are going to be over the butt, that sacrum area, that coccyx area, definitely above the butt where that coccyx bone is, where that tailbone is. Next, you're going to see them on the calluses of the heels, followed by the trochanter. So thinking about the hips when we reposition these patients. So when you are examining your patient and looking for all these areas where you might have skin breakdown, the heels are definitely something that you're going to want to look at. What you'll notice with these patients is that their heels become very boggy. And by boggy, I mean if you just feel your heel right now, it's very firm to touch. These become almost like if you have an orange that's rotted and it's very mushy, like you could put your finger into it, it's kind of like that. We call that boggy, and that occurs on the heels. And these are all very, very common areas where we see pressure wounds develop. It causes an occlusion in our blood capillaries, and then it's going to cause even poorer circulation to the tissue, and the wound's going to get even worse. We know anytime that we don't have good blood flow or any good circulation to these areas, we're not going to have good oxygen. We're not going to get good nutrients. If we don't get good nutrients and oxygen to that wound, the wound's going to develop into, it's going to be ischemic, which means that we're not going to get any oxygen. It's going to become hypoxia is going to set in. Then we're going to see more swelling, more inflammation, and then that area around that wound is going to die. Wounds in patients can develop in as little of 1 to 2 hours if they have not been moved or repositioned. So that's why we say every 2 hours. And this is a lot on just one person. So I always recommend you pairing up with your tech at the beginning of your shift and say, hey, look, we have 4572 together. She's a Q2 hour turn. You get the odd times, I'll get the even times. If you need me, come get me, or vice versa. If you can't get one because you're in a room, call me. You kind of have to think of a, a way to tag team together, to work together to make sure that these patients are turned. All right, so we talked a little bit about friction earlier. So friction can definitely cause a development of a pressure ulcer. So this occurs when we have two surfaces that rub against each other. So the patient's skin on the bed, the patient's skin against the lift sheet, the patient's skin against the chair, a variety of different things. So these wounds do resemble some type of an abrasion, but it can also damage those superficial blood vessels that we have under the skin. So we're always worried about patients that lie on wrinkled sheets. This can cause friction. So this goes all the way back to fundamentals. We haven't talked about this for a while, but in fundamentals, we talked about always making sure that if they had a lift sheet or a sheet on their bed, that everything was wrinkle free. Thinking about if we are moving a patient, having them on that lift sheet, thinking about where their elbows are, where their heels are, because if you're moving a patient over and their heels or their elbows are not supported, those areas of the body are going to drag across the bed, and that can cause skin breakdown. We worry about friction burns as well. That can absolutely happen on any area of the skin. Very common. If you just pull a patient up in bed up against the sheet, which you would never ever do, you should always have a lift sheet under them and actually pull them up in the bed. Shearing of the skin is when one layer of the tissue slides over another layer. And then when you think of someone who had that happen and they develop a shear, that's when the skin actually separates from the underlying tissues. So very, very common in our older adults because they don't have a lot of subcutaneous fat, and very, very painful. So what we see happen is that in their skin, they have small blood vessels and capillaries that are going to be stretched. And as they're shearing, they can tear. And then that's going to decrease the amount of good blood flow that we get to that area, which is going to delay wound healing. So these can happen. This can happen in patients who are pulled across an area rather than using that lift. And when we move them up in bed without having them on a lift and lifting them off the bed. A patient who is partially sitting up in bed is going to be susceptible to shearing force, because when the patient's skin sticks to the sheet, if you think about putting a patient, you pull them up in bed, and then you set the head of their bed up again. If you see them, how they start to slide back down in the bed again, that can cause shearing. So we have to be very careful about that. So what I like to do is I will lay the head of their bed back and then pull them up, and then I lift the end of their bed up, kind of make it so their feet are elevated. So then when I put their head of their bed back up again, they don't scoot down in the bed. That's one way that can help with tears from shearing. All right, so these are some of the common pressure points where we see injuries occur. So again, you have to be very careful. Make sure you're inspecting all of these areas. You're describing what this skin looks like, documenting it in your assessment. Any type of bony area, any type of skin fold where we have tubing applied, these are areas that can have skin breakdown, okay? So depending on what type of documentation you have, you might just be circling. If you are in an outside facility like an assisted living, you might have paper documentation. So you would just want to circle the areas on the body. In electronic medical records, you are just documenting them in the computer. All right, so what are some common things that you may see that can leave your patient at risk for developing some type of a pressure injury? So we definitely know aging skin, right? We lose that subcutaneous fat, the skin is more fragile, we don't have a lot of collagen anymore, so they are more susceptible to skin breakdown. Definitely chronic illnesses that delay, any type of good nutrients or blood supply to the body can cause pressure injuries. Being immobile. So if your patient cannot move on their own, they need to be turned, because we know if they're staying in the same nutrition for the same amount of time, that skin is definitely at risk for development. Malnutrition puts them at risk for not having good skin because they are not getting the proper nutrients. They're not getting a lot of protein in their diet. Certainly patients that are incontinent. So if they're incontinent of urine, if they're incontinent of stool. So on your part, you have to be very vigilant about recognizing if they're incontinent. And then you have to, maybe in your men, you can put in a condom cath, right? We don't want to go right to a catheter because a catheter is pretty invasive and we know the risk of infection that comes with that. But we can do condom cath in our men. We can do PP tacos in our men, which are kind of like these little round things that are very absorbent, and you can wrap the in them, and when they urinate, it kind of pulls the fluid out. We can use Pure Wicks in women to try and pull that fluid away from their skin as well. Any patient that has an altered level of consciousness that is not alert and oriented is not going to be able to move themselves and recognize the need to be moved, okay? Because they're not really with it. So you have to be mindful with these patients. Patients that have had spinal cord and brain injuries. So if they've had spinal cord injuries and they might be a paraplegic, they might be paralyzed from their neck down, their waist down. They also won't be able to have good control of their body to be able to reposition themselves. And then thinking about patients who have neuromuscular disorders as well. So Parkinson's, ALS, things like that. All right, so next we're going to go into pressure staging. Why don't we take a 10-minute break, and then we will come back at 5 after, and we will start with staging. Okay?
Sounds good.
Okay. See you in a couple of minutes.